All right, welcome to the Hip Injuries 101, Hip Injuries Explained. Those of you that don't know me, my name is Dr. 𝘵𝐴𝐻𝐢. I am the creator of the Peak Method and the founder of the Soft Tissue Revolution, where we basically teach massage therapists a new treatment method that focuses on working smarter, not harder, allowing them to make well over $100,000 per year with less than 20 hours of time per week in the clinic. My real goal of all of this is to basically solve the pain pill epidemic by helping people that are injured and in pain get access to quality hands-on soft tissue treatment so they can avoid bigger problems down the road like pain pills, injections, and surgeries. I believe the most equipped people to do that are massage therapists, but they're stuck working harder, not smarter. I want to change how they evaluate, change how they treat, do it more effectively, do it more efficiently, and also get them rewarded for the care that they do. So we're going to jump right into our Hip Injuries 101. All right. So I always start these webinars off the same way. How can you ever fix a problem if you don't know what it is in the first place? So much of treatment is just like, hey, just jump in there and kind of see what happens. It's very haphazard, doesn't really get down to the root cause of what's going on, and you don't really know. And this is why people aren't getting better in the conservative care model, because everyone's just basically diagnosing and treating based off what they're trained in instead of what the client actually needs. You would never do this with your car. You wouldn't take it to the mechanic and be like, hey, just start hammering away on it and see what happens. They want to run diagnostics and figure out what's going on. It should be the exact same thing with the human body, because it is way more complicated than a car can ever be. So in my method called the Peak Method, we have a very specific list of how we get to a problem. First is we got to get to a tissue specific problem list. Like I said, if you can't find it, you don't know what it is, you can't fix it. Then we start by restoring range of motion. Then we manage the load, because most people that are injured are doing more than they can handle. Then we balance strength with some corrective exercises only after we manage load and restore motion. Then we create increase overall strength with more global movement. And then our job after that is to maintain the range of motion as well. But we need to follow this process. It's kind of like building a house. And if you're trying to strengthen it or move it in a different, like put the roof on before you ever lay the foundation, you're in trouble. So the first step, and this is why soft tissue practitioners, especially ones that are good with their hands, are so important at getting in there and restoring that range of motion first. I have other webinars on this one and that they go more in depth, but there's 12 questions that I ask every client before we ever go in and do treatment on them or figure out what the problem is. Those webinars will be linked wherever you're watching this. But basically, I need to know how old they are. Are they male or female? Where do they feel the pain? What does the pain feel like? Then I ask severity of the pain. Basically, I ask on a 0 to 10 scale, 0 no pain, 10 they wouldn't care if we cut it off. We want to know when the last time they had that worst one and what it's been over the last 30 days. What can make it worse? Like what can flare it up? What can make it better? Second order history questions: have they had accidents or trauma? Have they had any imaging done? Have they seen any other practitioners? Did any of those practitioners actually render a diagnosis of what's going on? Did those treatments help? Do they do any exercising or working out? What do they do for work? And then lastly, I kind of connect with them on an emotional level and say, hey, how's this affecting your quality of life? I won't go through those too much in depth today, but basically what we're going to do with this webinar is I have what's called the 7 problems. There's 7 problems in the body: bone, cartilage, disc, ligament, nerve, soft tissue, and tendon. And based off that, and what we're going to do in this webinar is I'm going to go through where in the 12 questions this would show up and give you a better idea of what's going on. So let's jump right into it. First one is bone. Bone is a very common cause of hip pain that gets missed a lot. It definitely is a big factor in both an older and a younger population. In the older population, we basically just get osteoarthritis. Basically, it's just degeneration where the joint actually starts to wear down. It doesn't move how it's supposed to. Something that we end up seeing a lot in the younger population, especially like teenagers into like their late 20s, early 30s, is they actually develop this bone formation called a cam or a pincer lesion. So basically you have your femur and it goes into the hip. And over time, especially when they're growing, it actually lays down more bone in there and it kind of starts to jam on itself. So when you have a bone problem in the hip, it just has that limited range of motion, like almost like that hard stop and that hard feel. I tend to see this a lot when their activity level is high when they're a kid. You know, we see this where kids are playing like the same sport year round, and they actually have done studies and shown that they're 1,000 times more likely, 1,000% more likely to develop these CAM lesions as they go. And this idea in the body is called Wolff's Law. The more pressure you put into an area, the more force, the more it lays down bone. So a lot of these kids that are having cartilage problems, hip problems, they started with a bone problem there as well. And then when the bone doesn't work correctly, it just puts dysfunction in the joint mechanics, which in turn puts more wear and tear on the muscles, on the tendons, on the cartilage. And a lot of times with a younger population where they're coming in with a lot of hip damage, a lot of hip dysfunction, it started off as one of these CAM or pincer lesions. They just get missed a lot, but they are so common. Whoops. Next one is cartilage. Cartilage is a very commonly missed issue in chronic hip pain. It gets missed a lot. So one of the keys is like symptom location. A lot of times they'll have it like deep inside the hip or off to the side a little bit. They'll also describe the quality as like a popping, clicking, or like a sharp or stabbing with like a particular movement if they like kick their leg out or they move it internally. Usually with the intensity, it gets more intense as they use it or with particular movements. Provocative, yeah, definitely gets worse with movement or if they're actually just laying on it. Palliative, yeah, feels better when they're not using it. Lastly is trauma. Trauma is going to be very common in there too if there's like a huge impact in there. Specific activities in sports, that's going to be big too. That's what I talked about in the previous slide. A lot of these younger people are doing the same thing. They're playing the same sport year round. They're playing club, they're playing school sports, they're doing all this stuff, and they're just putting more wear and tear in there. And then basically what happens is it ends up causing problems in the labrum. So we went back and talked about that cartilage and that CAM type of problem. So basically your hip has to articulate in nice and free. And over time, when it gets those, they're almost like barnacles that grow on the hip. And over time it starts to jam into that cartilage and it starts to fray that. So a lot of people will present with cartilage damage in the hip, and then they'll almost be like, they'll feel like a popping or clicking in there when they do things. Sometimes it'll get really sharp with a particular motion. A lot of times what I end up seeing when there's a labrum damage, the hip is actually a little bit sloppy. So the hip is actually a very stable joint. It doesn't have a ton of movement and the muscles are really strong to keep it in place. That's why it's a hell of a lot harder to dislocate your hip than it is to dislocate your shoulder. Your shoulder is built for movement, your hip's built for stability. So what happens with that labrum is actually looks kind of sloppy. The hip has like a lot of give to it. It doesn't look good. And then another thing, when I do have a cartilage problem or that CAM or pincer type of lesion, you're going to get pain in the front of the hip. It is not a hip flexor problem. This gets missed so many times. People think just because the iliacus or the psoas goes down there, it must be a hip flexor problem. And they do all sorts of stuff, stretching it, jamming things in there, injecting it. It is not a hip flexor problem. It is a cartilage and a bone problem. Disc usually isn't going to be a main problem in hip injuries. Usually what I see is it's secondary from like low back sciatic issue, comes in from altered hip mechanics. So usually people start with a hip problem, then the back starts to compensate and they feel both. And they kind of go vice versa. It's usually like which one really started first. Usually that's where we're going to attack first. But mostly I'm not going to see a lot of disc issues causing problems in the hip itself. It's just going to be more of that compensation in there. Next one's going to be ligament. Ligament is actually really important in overall hip function. Definitely where they feel it. When they have a ligament problem, they might have it in the front of the hip, but they're definitely going to feel it on the side of the hip. And they'll describe it as like a tight, achy, kind of restricted type of thing. Symptom intensity, usually it goes in that, like if we're doing that 0 out of 10, 0, no pain, 10, you wouldn't care if we cut it off. It usually lives in like that 3 to 7 range. Usually gets worse with activity, better when they don't use it. Trauma in there as well. A lot of times if there's like high impact, maybe they play a sport or they're doing a lot of heavy lifting, that ligament gets stretched a lot. Also what they do for their job, are they a blue collar worker? Are they using their body a lot? Are they beating it up? And the ligament that I end up seeing a problem is called the posterior hip capsule. It's just on the back side of the hip capsule. Basically, it helps to attach the femur when it comes into the hip itself. And ligaments are like a ball of yarn that kind of open and support when this happens, and they get really stretched out. So a lot of those people that are coming in with that anterior hip pain, that tightness, and some pain on the outside of the hip, a lot of times it started as a capsule problem as well. When it's just strictly a capsule problem, they might just feel like that deep aching type of pain when they use it. They won't feel as much as like that popping and clicking. Popping and clicking means you also have that labrum issue in there as well on top of that ligament. So Nerve, there's 256 different places in the body where a nerve entrapment can occur. Very common. Key things with nerve entrapments in the hip is like where they're going to feel it. Usually what I'm going to find is there's going to be in the front part of the hip on the quad. They might get a little bit on the lateral aspect as well. They'll describe the pain as like a numb, aching, burning tension. And usually what happens is when they're actually using it or they're moving it, it increases some of that aching, burning, and tension. When they're not using it, it feels better. A really common nerve entrapment that I see is the femoral nerve. When it comes down on the front part, it comes out through the psoas, and a lot of times it gets caught in the 𝘭𝑓 junction in there. So if the client's coming in with like numbness and tingling down the front of the quad, but they don't really have any like back pain associated with it, then I start to think that this could be more of a femoral nerve problem. I don't see it that often, but it is one of the nerve entrapments that can create some hip pain. All right, soft tissue, my favorite thing to treat. It is the most common cause of a lot of problems that we see in the human body. Basically, over time, muscles get overworked with bad postures, doing too much, not taking care of ourselves, getting beat up, and it makes those muscles weaker, less flexible, form scar tissue. So definitely where they feel it, what the quality feels like, they're going to say, you know, like dull, achy, tight, that kind of stuff. Severity, same as a ligament, it kind of lives in that 3 to 7 range. Provocative, definitely feels worse as you use it, better when you don't use it. Have they had trauma? Yeah, when there's trauma, there's going to be a lot of scar tissue formation as well. What they do for activities or what they do for a job, are they sitting a lot? Are they doing a lot? Vice versa. And I tend to find this a lot in the muscles of hip flexion, you know, specifically like rectus femoris, iliacus. I see it a lot in the adductor magnus, gracilis, and a lot of those deeper muscles. And I will see it a lot in the posterior hip capsule as well. Last is going to be a tendon. Usually with a tendon, the older they get, the more likely they're going to have a tendon problem. Symptom location is going to be specifically where they have this. And two common areas for dysfunction are going to be on the patellar tendon and the rectus femoris tendon, where it starts at the top of the hip. That's where they'll kind of point and say they feel that. A lot of times with a tendon, it feels worse when you use it. Palliative, it's better when you don't use it. If there is some trauma in there, that tendon gets overloaded. Activities or jobs, what they do for their jobs can definitely cause them to put more wear and tear on their body, or if they're really active, doing a lot of stuff. And I've talked about this before, but there's two types of problems in the tendon. A lot of people just think tendonitis. Tendonitis doesn't tell us anything. It just says the tendon is inflamed. It's what I call a junk box diagnosis. It doesn't give us any real information. What most people end up having is a tendinosis. What that is degeneration of the tendon around it, because the soft tissue isn't working correctly. There's nerve entrapments, there's problems in the ligament. The body has to generate force from somewhere, and it goes through and puts more wear and tear on the tendon. Most people that end up having a rupture, 97% of them were tendinoses before they started. The tendinosis is a big problem. It gets missed a lot. And a lot of times when people have a tendinosis, they're just doing way too damn much. They're not recovering properly. They're not getting the right range of motion, all that stuff in there. So common diagnoses that are completely wrong. I talked about this earlier, hip impingement or hip flexor strain. You know, so many people think just because it hurts in a certain area, that must be the problem. It's not. It's actually that bigger problem of either cartilage problem, cam problem, extra bone growth. So don't default to the idea that just because it hurts in an area that must be the problem. Next one is hip bursitis. Anytime you have anything with an itis in there, there's some swelling. It's just code word for the doctor or the practitioner has no clue at what's actually going on. You have to ask yourself the question, why is that bursitis happening? Why is that hip getting overloaded? And a lot of times because other things aren't working correctly. So many doctors and practitioners go in to try to get rid of the bursitis with an injection, anti-inflammatories, but they never actually got to the root cause of what's going on. Next one is a lot of younger teenagers and other people, they will have surgery on the labrum. The problem with the labrum is it doesn't get good blood flow. It doesn't get good oxygen. So it takes a long time for it to start to heal. And a lot of times they never actually address the biomechanical problem or the limitations in there, specifically on those cam and pincer lesions. So they fix the labrum, but the problem is still in there. Think of the labrum as like your thumb, and it's stuck inside a car door. The car door is all the scar tissue around there. So you can't fix this till you remove this. So a lot of people jump into surgery and maybe they'll free it for a bit, but then it jams right back down there. Last one is just IT band syndrome. I would say anything that has syndrome in it is just code word for they have no freaking clue about what's going on. And a lot of times when I see like IT band syndrome, it's because that IT band is having to work a lot harder because there's dysfunction in the muscles in the hip, specifically like in the adductor magnus. So the adductor isn't doing its job, so it's putting more wear and tear on the IT band. So like say you went and ran 5 miles, a lot of times when there's an adductor problem, maybe the adductor can only produce 1 mile of force, so the rest has to go there. So your adductor might have ran a mile, but your IT band ran 10. And that's why it's having problems in going in there. So you have to continue to ask the question of like, why is this area hurting? And a big question that you always must ask is like, was there trauma or not? If I have pain, but not a lot of trauma, there's a compensation. And usually the muscle or the area to complain is the one doing the extra work, not the one actually causing the problem. So really diving in with the 12 questions and being able to figure that out can help you get to that tissue specific list. So what are you going to see the most? You're definitely going to see scar tissue in the muscles, the nerves, and the ligaments. For sure, those muscles just get really beat up. You are going to see in the younger population that labrum and that cartilage degeneration, and then in the older population, you will see that osteoarthritis. Also, in some cases, you will see a tendinosis of the patellar and rectus femoris tendon. Those are going to be your people that are just doing way too much, that, you know, they're working out. If they're 7 days in a week, they're working out 10 days in a week. They're not taking rest. They're not doing that. They're just really beat up their body, been hard on that as well. So how do we go about fixing it in the PEAK method? First is we just evaluate global motion first. We look at hip flexion. I look at the flexion of the hip, and then I also see how the hip flexors are lengthening as well. That gives me a really good idea of how that hip is moving overall. Then we do manual and instrument-based scar tissue treatment to restore the range of motion. And we treat the scar tissue in the muscles and the nerves and the ligaments, specifically those muscles of flexion. So I do a lot of work in the adductor magnus. Nerve-wise, we treat around in the iliacus, around the femoral nerve, and then ligaments, we treat that posterior capsule. I do a lot of work manually and with an instrument on the rectus femoris, really kind of cleaning that up. Then we just need to manage the load of their hip, because at the end of the day, people are injured because they're doing too much. And our job as the practitioner is to improve their capacity. Capacity is what they can take, load is what they can do. And we're fixing their capacity, but if they keep doing too much load, it's not going to get any better. So we have to get them to cut back, because if they don't cut back, it's never going to be able to solve the problem. And it's not forever, it's temporary to allow them to continue functioning pain-free down the road. Your job is to help them see the big picture. They think very short-sighted. Your job is to think long-sighted and be an advocate for their future health and their future well-being, despite how they want to be. Then we get into some corrective exercises to the hip flexion muscle groups only after range of motion is restored. We don't need to get on there. The muscle is tight and it's weak because it has scar tissue. So when we treat the scar tissue, we restore the range of motion, then we build the strength back up with corrective exercise. But we don't do that before we restore range of motion. That would be like trying to put a roof on a house before we ever have a foundation. And then after that, usually we move into addressing the lumbar spine dysfunction, because usually they go hand in hand. Usually it starts as a hip, or it goes to the low back, or it starts as a low back and goes to the hip. That's when we start to kind of go more global. So we start working more regional, and then we work global and work our way through. Thanks for watching. And if you have any questions, leave them below, and we'll be sure to answer each one. Get access to our free training. It's all listed below. And if you have any topics or questions specifically you have, reach out and send it over our way, and we'll be happy to help. Appreciate you guys watching, and we'll see you on the next one. Bye.